Good morning and welcome to Projecting Service Capacity and Revenue, the key to planning a successful future, a webinar sponsored by the LA County Substance Abuse Prevention and Control. I am Kim Waterman, Project Coordinator at the California Institute for Behavioral Health Solutions. We will have two speakers this morning, Amy McIlvaine, Project Director for the LA County Training and Technical Assistance Contract, and Andrea Jones, CIBHS Coach. Please note that all attendees are in listen-only mode. We do encourage you to submit your questions at any time during the presentation. You can either type your question in the questions box, or you can raise your hand. So for those of you who are on the webinar, if you could just as a test, click on the raised hand icon now. Great. Okay. And then when I see you raise your hand, I'll let Amy know there's a question and we can unmute you. Also, if you don't feel comfortable speaking, you can go to the question section and chat it in and I will read your question. If you pre-registered, you should have received the Projecting Revenue and Capacity spreadsheets by email from Kim Waterman. If you did not receive them, you can download them now from the handout section of the GoToWebinar control panel. I'll also send them out again at the close of the webinar. There will be a brief survey at the end of this session as you exit GoToWebinar, and we do thank you in advance for taking a few moments to share your feedback. We do read your comments and use them to inform future trainings. So I'll go ahead and turn it over to Amy to begin the presentation.
Thank you, Kim. I appreciate that. And I just want everyone to know, Kim, do you have a rough estimate? We're not expecting a whole lot of people today. Can you tell me how many people we have on that's on the webinar?
10.
Okay, so this is going to be pretty informal. And I know that some of you have also signed up to come to the April 13th workshop where we're really going to be able to do a deeper dive and work. I'll be able to work with each of you individually to help you really answer site-specific or agency-specific questions. So what Andrea and I are going to do today is just give you an overview of how to fill out the spreadsheet and hopefully just make you feel a little bit more comfortable about putting information into this spreadsheet, which can in some ways look pretty daunting. Could you type in the chat box, or would that be the chat box or the question box? How many of you have attempted to fill in the question box? How many of you have been able to just start dabbling a little bit and have entered some numbers either into this spreadsheet or into the spreadsheet that we had before we did the new, I'm going to say it was more of the black and white issue, and this is the colorful issue, the SAPSI sort of edited and perfected spreadsheet. So again, if you could just let me know if you've attempted it, because that helps me, kind of see a little bit too about what kind of detail we go into today and how to get started.
I see one person has raised their hand so far.
Okay, great. Well, that's good then. That gives me a nice place to start.
2 people now.
It sounds like we're all right.
3.
Excellent.
Yeah. Okay.
3. Good. So one of the things for those of you who have actually tried typing in some things and entering some information, you might already have some specific questions that you want to ask. And so I would encourage you to either, if we don't cover it today, make sure that you stick it in the question box before we leave. And or if you're coming on Friday, we'll also have an opportunity to really look at those site-specific questions. So to start out,
Amy, one organization. Oh, sorry to interrupt.
Yeah.
One organization said that they've done some work on previous versions of the spreadsheet, that they haven't yet done any work in the newer version.
Okay, that's perfect because that'll be really wonderful. I think the page that Andrea is going to cover with you is probably the page that changed the most. And as far as I'm concerned, it's for the better because it calculates your group costs much better than it used to, which I think is really a blessing. And then it also makes the tool much more valuable to use as an actual tracking sheet if you want to use it, not only just to project, but also to kind of start to get a finger on, exactly what it is, how much you're billing and what your capacity is week to week or month to month. So that's perfect. Good. So again, today, just three objectives, really. Just want you to get a little better idea of how this spreadsheet really fits into great fiscal and clinical management. We're really hoping to help you successfully complete this spreadsheet, and this is a great stepping stone tool. I say it's really laying groundwork for good decisions. We can't run a business if we don't have a good idea of, how many service units we're selling, producing and selling, and we don't know how much money we're making from week to week. It's sort of like, I think it would be a really scary place to be. So we want to help you feel more comfortable and have a way of accessing and, really documenting this information. And then we're also going to show, I'm just going to talk to you a little bit about how you can customize this form to maybe make it fit a little bit better with the information you need to track, as well as, looking at this as not only a way to project your revenue, but also as a tool to, kind of continuously collect data to see if you're on track for meeting your target revenue and your target service capacity. Pretty simple. And so this slide basically is, I'm going to just kind of help you figure it out again. If I said, I want you to meet me in Los Angeles, that would be pretty daunting because that's just an overview of what Los Angeles looks like. So generally speaking, when we're going to, start to make decisions about things that we're doing, we need more detail. So, and some of you have heard my, map analogy, and I want to, sorry that I have to repeat it, but I think it's a good one because it just really brings it down to basics. So I could start with saying, meet me in Los Angeles, and you would be like, what do you mean, meet me in Los Angeles? So oftentimes we start to give things more detail. So for instance, I might say, would you please meet me in Los Angeles? And we're going to meet, I could say, let's meet at the corner of North and Main. And you might say, oh, that's pretty vague. I don't really like that, but that's okay. I'm starting to give you a little bit more information so you could start to maybe figure out where it is that we're going. But I could continue to give you extra information. I can say, I want you to meet me at, 222 La Brea next to the Donut King. And then you've got more information. You know where I'm going to be, but now you still want more information, like what date, what time. So, as we start to have interactions with people, places, things, our business, we need to figure out how much detail we need in order to make good decisions about where we're going. Also, you could think about this big picture of meet me in Los Angeles, and you could decide, well, if we're walking, we would have different kinds of mile markers. We'd need different information. If we were taking the bus, we would need information. And then I thought to myself, well, what if we were, one of those helicopter pilots, and we were in the, we had the police helicopter. We might even be looking at GPS quadrants where they would be able to give us exactly the location that we needed to be. And much like when we're driving in a car and we want to know where we're going, we need to have that same kind of level of detail when we're trying to figure out if we're making the right amount of money and if we're making good decisions about our business. And the two fundamentals, again, are you are in the business of providing services, so we definitely need to see if we're meeting our capacity to provide those services as dictated by our billing and capacity sort of spreadsheet overview, the minimum, maximum hours that we can provide. That also we need to know if we've got enough staff to do that. And we want to know if we're going to make enough money to cover our expenses, but we don't want to make too much money because if we do and we get reimbursed, then we might have to do a recoupment at end of year. So we need to kind of figure out those four different measures. Again, it's how many service units are we going to sell, because that's in essence sort of what we're doing, because it's the prescription that we're providing patients to get well in our community. And that's something Gary talks about sometimes is this prescription. We also have Jan Tice, and I was with House of Hope, and Claudia starting to, she was using that verbiage too, because I think it's a good way for us to understand that our services, and when we document, it's not just that we want to write up a bunch of stuff about what we're doing. It's really, that's why we're in business. We're in business to provide therapeutic services so people get well, they go down the continuum of care of recovery. So we can track that on this spreadsheet. We can figure out if we've got the right amount of service staff to provide those units, and what is our balance between the personnel that we have doing direct service staff, and what's our balance between people who are just having to run other functions to make sure that our business is working. And then we can look at our expenses and see, first of all, if they're allowable expenses and if they're going to be covered, and if our mix of services and expenses is just the right balance so we don't have to give any money back at the end of the year. Or if we see that we're making a little bit of money, do we have enough information so we feel comfortable spending it rather than having to allocate at the end of year and giving it back to SAPC? Because to be perfectly frank, SAPC would be just fine if we reinvested in our business to improve our services, maybe do additional services, treat more patients, expand, because there's a need out there. All right, so now I'm going to switch my screen and we're going to open up some of our spreadsheets. And the first thing I'm going to do is go to my gigantic one, which is huge. And we're going to look at this first sheet. And Kim or Andrea, does this look fairly decent for everybody? Can you see it?
I can see it very well.
I can see it too.
Good. Good. So you'll notice that this is, and if you can kind of see my scroll, you'll notice at the very bottom left-hand corner of the spreadsheet, and this may seem a little remedial, but I know that the first few times I started using Excel spreadsheets, I was a little overwhelmed, and it took me some while and it took me some practice. So I'm just going to tell you a couple of things that I'm going to show you also some Excel tips. So at the bottom of the page, there's these tabs. We have a tab called Program Budget. I can click over here and we have a tab called Service Model Projections. We have another tab called Service Unit Model. And then we have a tab over here called our Staffing Model. And so sometimes I know that when we first put this out, there were people who weren't aware that this was actually a multi-tab document. Also, what you'll notice is that this is set up, I kind of call it a macro spreadsheet. So formulas that, some of the information that you enter in one of the first tabs may actually be calculating something in one of the other tabs. So there's some formulas that were created, and the joy of this is if you're not really savvy at doing Excel, someone else has done that work for you, because that I think can get kind of complicated pretty quickly. So that's already done. If you wanted to add a tab, you could go over here and you could add a new sheet. And I'm going to just tell you that really quickly, because it might be that you want to start tracking this on a monthly basis, like maybe your service model projections or your service unit model. So if you wanted to add one of those sheets, you could either you can right click on it and you can have the option of moving or copying a sheet. Or you could also just add a blank sheet. But if you wanted to add another sheet, you would be able to click on that and it would create another sheet like this. And then you could rename it and say, well, we're going to use this as our tracking spreadsheet for the month of May. And so that's kind of a cool thing, because all of your formulas and everything will stay in there and you don't necessarily have to create a whole new sheet. Although you have to be a little bit careful of adding. The other thing that I might suggest is if you wanted to track it month by month, I might just, if it was me and I was doing QIUM, or if I was an accounting department and I wanted to track what my service capacity looked like, I would probably just copy and save this and I would rename it as another month. I would have one for June, July, August, September. So that's sort of some ways that you can use this. So let's go back to Program Budget. You'll notice that way at the tippy top of the page, it says DMC outpatient services. And remember, outpatient, intensive outpatient is also, you can use the same form. I realized that we should probably change the title of this to reflect both inpatient and outpatient, and I will do that post-call. And there's these two blue lines which clearly differentiate between our staffing levels. We have Schedule 1A, which is those staff who are directly involved in providing services that we have to document and then bill for. They're usually what we consider people who are who are credentialed or certified. Like, for instance, I could have a lovely conversation with a patient, but nobody's going to pay me for that because I don't have the credentials I need. So if I was working in your organization providing some functions, I would have to go down into Schedule 1B, which is indirect salary and wages. And you'll notice that Schedule 1A are your direct salary and wages. So let me just quickly talk to you a little bit about these position titles. These are professional position titles. Now, I can tell you for one that I have gone through and I've done some spreadsheets with several locations by this time. And there's not a lot of people that are really using this language to describe who you have on staff. However, this is the language that SAPC wants people to start looking at and think about, because again, one of the things that we're doing with the DMC waiver is kind of thinking about how we're going to transform our system of care to be more whole person centered, and which means we're going to be thinking about, we're specialty care providers working in the healthcare industry, and these are healthcare industry standard language for position titles. So as you start thinking about, keep moving towards that, whole person centered care, you may want to just kind of think about elevating some of your descriptions for your positions to use some of these just certified, I don't want to say certified, but standard healthcare language. So the medical director, and in this particular case, we have a little slash and it says physician. This, again, I'd like to really draw this one out because this is the thing that I find is most different in many of the places. Some of you will have a medical director who's on staff and maybe getting an hourly wage plus taxes and benefits. If that's the case, then you would want to make sure that your medical director's hours were in Schedule 1A. If your medical director physician is actually a contracted employee, like you pay them a set amount of money to work a set amount of hours per month, and they pay their own benefits, then that person would actually go down into the Schedule 1B, indirect salaries and wages, because as you'll notice, this schedule, we're going to calculate our taxes and benefits. So I noticed there's also sometimes some of our other positions, maybe even your licensed clinical social worker, may also be a contract employee with just a set income per week. Then again, you would put that person, you would have to put their indirect salaries and wages. You have to just figure out how you're going to calculate those benefits. So that would be a nuance, and that would be a great, if you're having questions as to how you want to do that, it's just kind of up to you. Where do you want to stick that person? There's other ways that you can just kind of put them in as a line employee. If the person, so for the medical director position, it's a little easier. If your clinical licensed social worker actually provides direct care and they see patients on a regular basis, then you're going to want to make sure that they get in Schedule 1A, because these staff, you'll notice when we get into another tab, it's calculating everybody you put in here helps you identify whether or not you have enough people in direct service positions to provide the number of services that you've estimated. So it's important to make sure that you figure out in some way, shape, or form where those people go. And again, I find that you probably just want to give either myself, you give me a call, and also Andrea and Victor are going to be doing another workshop, which we're going to post shortly for all SAPC providers. But we can go specifically and delve into some of those questions as to how you should handle that.
Amy, I did have a question come in.
Yeah, great.
You were talking earlier about copying the tab and tracking the information monthly. And we had a question about when you add extra tabs, would you input the information for one patient? Or how do you handle that with multiple patient information? So it says if you were to track by month, would you input the information for one patient?
That's excellent. And again, that's sort of, part of it depends upon what you can do is you can kind of do an estimate of, you can look at the service units that you've provided for a week. And if you have a smaller organization and you're not doing a whole lot of customer transactions in a day, you don't have a lot of patients that are coming through your facility, you could do it where you would actually track, by caseload. For instance, if you had, probably the easiest thing is a residential facility and you had, maybe 10 beds or 12 beds, you could really track each individual person to figure out how many units of service they had. And there would be a few things that you'd want to do to the spreadsheet that would be a little bit different. Say you're running like AVRC, the county facility, they have 160 beds. So they're probably not going to go and, figure out what each person is doing, but they could still be doing, looking at averages. Are we meeting our minimum and maximum? And then you could put that into this spreadsheet on a month-to-month basis. So I would need a little bit more information for me to be able to say, this is how I would do it, or this might be what would be recommended in that particular situation. But that's an excellent question. And if somebody wanted to contact me afterwards, we could kind of talk about those nuances, because I think that's a really good thing to think about. And how do you want to do that? And part of it would be the workload and how many resources you had. Do you have people who are really good at accounting and who are actually allocated to track that kind of work, or is it something that somebody else is going to have to do? So just how detailed you need to be. And if that doesn't make any sense, or you want to give me your contact information, type that into the chat box, then we can have another conversation about that. As that is a very good question. Yeah, excellent. So then the other thing is, you'll notice like we have one whole person. So let's look at this. We have position titles. And again, if you feel better using your own position titles in there, you just go right ahead. It's really easy. You can just click on that cell and you can backspace and you can just type right over it, and you can add your title. And then you'll see that there's this little abbreviation called FTE, which stands for a full-time equivalent. And you'll notice that we have 0 there because our physician is actually contracted in this example. We have our licensed clinical social worker is actually providing full-time services. We're really busy and we had to allocate one licensed social worker to do that. But we also have an intern who's only working 0.50, which means this person only provides 20 hours or half time. Are they actually working directly with the patients, providing direct service care? So that's how you kind of allocate partials and full times. Now this person, you'll see the clinical psychologist who is licensed, we only allocated 0.15% of their time, because you'll notice in Schedule 1B that same person is actually, I'm going to be saying that I lied because I didn't do this. Your clinical director here, I have to change this, is actually 0.85. I had changed this, but I forgot to save my file. I apologize. So they're actually running both of these positions. They're running, and I'm going to change my hourly wage too. So they are not only, they're seeing customers, and 38.22. They are seeing customers and they are also supervising. So as a supervisor, 85% of their time is spent supervising other people. They're not actually in a direct billable capacity. And I can go through and we can kind of talk about each of these people in that regard. And I'll just kind of, and I'm going to ask if anybody has any questions. Otherwise, I'm not going to go into that detail. But you just basically have to list, all the people that work for you, if there's nuanced titles. If, for instance, you'll notice in the SUD counselor certified and registered, in this particular location, we actually have 3.5 individuals that are working as counselors. You can, again, if there's a real disparity in the amount of money that people are making, if you think it's going to throw off your budget, and sometimes this happens historically, a new person may make, $5 or $7 less than a more seasoned employee. You could, if you wanted to, just add lines and add more staff, or you could average the wage. You want to get an indication. But for this case, most of the people are within the same, sort of in the ballpark. So we just use this one standard wage. And then we have just one registered. Yeah.
Oh, sorry. Right. We have a question related to that. It says many of us use a standard federally approved indirect rate, which is applied to all of our direct costs. There's a question as to whether we would be able to unlock the sheet or build in a standard indirect rate cell rather than itemize indirect costs.
You could do that, and I'm going to look down below what I'm traditionally seeing, and I scroll down for expenses, the direct and indirect. That's at the bottom of the page. I wouldn't recommend doing the necessary. I would make sure that I itemize my salaries, my staffing. But does this answer the question? Because this is what people are using. This is, when we're actually looking at our expenses like rent, lease, equipment, those direct and indirect costs are actually being calculated down here. So is that what someone's referring to, or do they actually lump in their salaries also, their staffing hours?
They're referring to insurance executive management.
Okay, insurance rates, what you pay for insurance, lease, workman's comp, those sorts of things. Is that a human resources staff person? And I'll just kind of talk about this. This is what SAPC is going to recommend. If any of you have had a TRR, which is a treatment readiness and review, the staff that are going to come through, and specifically the contract staff, are really asking you to look at it at this sort of, in this way of looking, pulling out your direct salaries and wages and your indirect salaries and wages, and then looking at your other costs of doing business and putting those into Schedule 2, 3, 4, and 5, which is very similar to what you do for a report out when you're submitting your annual projections for the county. So again, you could do that. You could morph your sheet, and you could actually add your indirect staff. Personally, I wouldn't recommend that, because most of the expense in running an organization, a service organization such as the one you have, your expenses are going to be in your salaries and wages. And you can kind of see part of that is in our little program budget over on the right-hand side, our pie chart over here. And so if you're trying to manage your budget, you're going to want to have some ideas, because oftentimes our salaries and wages can be a little bit more flexible. It's a way of us to either make decisions about, I think we really do need to get a quality assurance person in, because between, making sure that we're documenting correctly and entering our information into our, into Sage, we're making some mistakes. So I really feel that we need to have a utilization manager and a compliance manager on staff. I think that's really going to support some of our decision making. I would want to see that as a separate line item. These other expenses like building costs, toilet paper, toweling, paper, pens, you can also break that down, and we're going to look at that a little bit, so you can kind of manage your budget again. If you start to look at it, you go, ooh, I think we're just not meeting payroll. What do we do? You can look at your expenses, and you might want to have a little bit more of a finite line breakdown. And again, it's really preference how you would want to do it. But again, my recommendation would be to make sure that you're looking at your salaries and wages more specifically than lumping them into the indirect budget. That also includes rent, insurance, new bushes, new plants, whatever.
So there's a follow-up question as to whether the indirect costs related to the agency would go into Schedule 5 then.
And again, this these schedules, Schedule 2, 3, 4, and 5, and I think I have this other page open. When I go over to the county here, and this is, most of you, if you can kind of see my little itty bitty mini screen, I look at these provider manual and forms. I keep going down here and I keep looking for information. I go down to the finance related forms and documents. So you have your cost report forms and instructions. The other thing that I really look at is you can look at your budget narrative and you can look at your budget summary. If you feel comfortable and it matches, sort of what SAPC recommends here, then go for it. Do whatever, especially if it's working for you. If you have questions specifically about each of these costs, I would go back and check in with my financial analyst at SAPC, because again, there's a level of detail and intricacy, and also this is shifting just a little bit. So if you have specific questions about what goes in Schedule 5, what goes in Schedule 4, 3, and 2, if you're not getting your questions answered by going to the county website, you should call your analyst and ask them if you're putting it in the right place, in the right spot, because there could be endless questions about that. And again, if you're not getting the support you need, or you want to check in with me afterwards and explain that in a little bit more detail, we can review that. But I'm just sort of a disclaimer. This gets kind of tricky and weird for different people. Some people have a real good handle on what goes into each of the schedules, and then I've worked with other people that are a little bit unsure of themselves. So I like to handle that on a case by case, because it's pretty hard for me, I apologize, to just generalize, if that makes any sense. And feel free to add some follow-up detail, and then I can get back to you, because these are all excellent questions and really, really important questions.
Great. Thank you, Amy.
All right. Yeah, thank you. And thanks to everybody for sending out these good questions. This is terrific. So one other little disclaimer is anything in yellow is a formula. So if you're not familiar with Excel, when you're doing a formula, you never want to hit the delete key, because as you'll notice, I've got this cell, which we're calling it cell. It's on line 4, and it's in column D. So 4D has a formula, which you can see in the upper bar here. I just kind of grayed over it. That is a formula, and that's what that formula looks like. So if you hit delete, you're going to accidentally wipe that formula, and unless you, and I'll just say a disclaimer, always save a copy of your sheet periodically, and also save a raw template. In case you accidentally do delete the formula, you can always go back in and rekey in that formula so you can fix what you did, because I can guarantee that you're going to accidentally delete a formula somewhere along the line, because it's pretty common, pretty normal practice. And then the other, let me think if there's any, which I probably just did, right? I tried not to do anything different, but you have to be careful with that. So then when we're going down, you'll notice that the other important thing is I want you to look at your taxes and benefits. And I'm just going to go over here and make a punch here. There's a salary subtotal. Your taxes and benefits are here at 0.32. If that isn't your taxes and benefits, that's average, that's industry average. If that's not what yours are, or if you don't offer any healthcare insurance or something like that, that may go down a little bit, and you can adjust that accordingly to your particular location. But that's just an average. And there we go. That was tabulated. So again, that's a formula. If you add cells here, you will also get this totaled here. And this 9.15 we're going to show is going to show up a little bit later on your spreadsheet, because that's the amount of people, and multiply that times 40 hours. That's how many service units you can actually provide in your organization then. So then you do the same thing for your positions here. And here's, again, these are recommendations for position titles. If you're small, you may not recognize all of these. You may not have those. Again, for instance, if you don't have a person on staff that provides your grounds maintenance and engineering, but you contract that out, it may not end up in your Schedule 1B indirect salaries and wages. That might be a contract service, and then it would go down into your Schedule 2, 3, 4, or 5, your direct and indirect operating costs. And again, there's larger facilities that actually have to have someone on staff full time. So that's why we wanted to just make sure people understood that. The same thing with security. Some people have full-time staff. Some people have that as a contracted person. Some people don't have security. So all of these are examples of some of the positions that you might have on property. If you have more than that, there's 3 blank lines. If you need more, again, if you don't have grounds maintenance and engineering, but you have someone else on staff, you could easily just, type right over that and you would get it. One of the things that we're noticing more and more is that people are having to allocate time for people to do outreach to make sure that their census is up. And we did put somebody in here at 50%. They also are an SUD counselor, so they're also allocated on the top because they do direct care 50% of the time, and 50% of the time they're providing outreach, but they're not actually able to bill for that. That's not case management, which is up at the top, the case manager. And so there's your schedule releases. The difference between this sheet for residential, the only difference that you'll notice is that there's going to be another line item budget in here, which is going to reflect your room and board costs, because you, again, SAPC pays for room and board, but the state does not reimburse you for room and board. So when it comes to reconciliation, you need to be able to allocate those expenses separately. You can't just roll them up into your budget, because they want to make sure that none of the state funds are being used to pay for room and board expenses. Okay, so then we're going to go to the next sheet, next tab, and I'm talking a little bit longer. That's probably equally, this sometimes is the most daunting for people. It's sort of your first start, and it's important to kind of get this right, but I did spend kind of a long time on that. This also, if you're coming to the workshop on the 13th, again, if you don't know every single solitary person on your staff, we're going to talk through this. If you have a payroll record that you could just kind of bring, so we kind of get a feel for what it is and where you might need to add people or lines, that would be great. I do recommend that you bring something in. You can keep it very private and personal, or if you just have a list of titles, and we can kind of figure out how many hours to allocate and the hourly rate. That's really, really beneficial. If you come with this already filled out and you just need to kind of like edit it or massage it or improve on it, that's also a way of doing that for the 13th. But if you don't want to, really get started on entering anything, that it is important to kind of have a good idea of what staff you have on board and how much money they make. And also you can just bring us your SAPC budget, and we can put that into Schedule 2, 3, 4, and 5 when you show up on Friday. That isn't an issue. And now we're going to move over to this over enlarged sheet, and Andrea is going to talk to you a little bit about this top half, and then I'm going to switch to a spreadsheet that's a little bit smaller, where Andrea will kind of show you how you're going to start to enter information.
Good morning. Thank you, Amy. So this spreadsheet, on this tab, it is our service model projections, and this is where we can project our services. And so, Amy, if you could go a bit to the left, I'm going to show everyone the different columns here. So one of the first things you would do here, as you can see on row 4, where it has the HCPCS, you would enter your codes here. And so here we have the H0049 and then the H0001. We would enter the codes that you would be using for your agency. And then in row 5, you'll see the service. So you just put the names of the services that your agency provides. So we have screening, we have assessment intake, we have counseling, we have updating the treatment plan, family therapy, collateral, and medical services. So those are a few of the services that are available that you can put there for your agency. Again, it's agency specific here. And so thank you, Amy. And then in cell, so you would enter that information, and then also here in cell A6, this is where you would enter your level of care rate. And here we've entered $32.01. And the other, you see where it says unit rate in cell B6? All of the cells in yellow, they are all a formula based upon what you put into cell A6. And so, Amy, if you wouldn't mind clicking on one of those yellow cells. So here it's 0. Here this says it's going to equal. So the assessment and intake, you'll get the $32.01 for, because it's linking back to cell A6. Here under in cell H6, we have a formula. And as Amy mentioned before, you want to have a little restraint and not delete any of the formulas. Thank you, Amy. So this information you would include. Also, if we go to cell B10, B10 is where you would enter your average number of your current caseload. And so here we have 30, and it's really important to try not to estimate. We want to try to use actual numbers as much as possible. The next cells that we would enter would be H and I. What's that? Yes, 8 and 9. So here you would put, this is only for group counseling and education groups. We also have group counseling in cell O, and so you would put the same information there that you would put for H usually. And so, yes, thank you. And so this current cell, cell H8, you're going to put the number of minutes. So it's either usually going to be 60 or 90 minutes of your group sessions. And then below it, excuse me. And then the next box, H9, is where you would put your average number of participants.
Hey, Andrea,
yes.
We had a question come in. For residential, is it 0 or the day rate for a residential level of care? And the person's asking because they see the day rate for residential is put in a different cell and they wouldn't want to reflect it twice.
So then I'm guessing that person is looking at the residential tab, since this is outpatient.
Okay.
Yeah, we'll quickly show the difference between, there's a whole nother worksheet for residential.
They said, sorry, they meant to say a 0 in the level of care rate, LOC rate.
Oh, for screening. In cell C6. Yeah. So for screening, you don't, it's not a billable service.
Okay, it says there's a cell in the residential, no A6. Okay, I'll try to send a follow-up and see if I can get clarification on the question.
The residential spreadsheet, we're going to quickly talk about the difference, but there is a difference because this whole top bar, this sheet, service model projection, is different for residential treatment, and we'll give you a quick overview of what that looks like. All the other tabs are pretty similar except for this particular one. So there is a difference, and we'll quickly show both of these top tabs.
Oh, great. Okay, they are asking about cell A6 on the residential spreadsheet. So whenever you get to that, we can look at that.
Great.
Okay, thank you. And so, so here in column H for H8, 9, and 10, you would add, for, as we said, the 60 or the 90. Here we have 60 minutes. And then we have, and then we have 12 listed as the average patient ratio. And then we're going to use 3 units here for documentation. And that's explained to us, as you can see in cell J, what are we here? J8, J9, and J10. And so that's what would go in H, in columns here, H, I, and then O. Are there any questions before we move on? Okay. And then as we move down in the schedule, so Amy, if you would just scroll down. I know it may be a little difficult with the free screen on.
And I'm actually gonna go to this one because I didn't have anything entered in those other ones. But
understood. Thank you.
Yeah, we'll just change that. There.
Thank you. And so, let's see. And the next thing you would do, and again, this is also agency specific, is you would add in row, you see row 14. So in cell A14, you would begin to add how many weeks or the term limit of your program. And so you have week 1 through week 1 down through week, here we go through week 12, but this goes down, this opens up, the spreadsheet opens up, and so it goes to week 52. But if your program only goes to week 12, then you stop entering at week 12, or if it goes to week 4, then that's where you could just enter your information and stop entering at week 4. And so here, if we go to this cell, it's at D14, you'll see that for the assessment and intake, we had just one. So for a patient stay, the average patient stay, they will have 1 unit of service here. And then for the initial treatment plan, they would have 2 units of service. Everything is really straightforward. The difference is when we go to the group settings. So we could go to cell H14. Here you will put in.
Okay.
Go ahead.
Andrea, I'm just going to make a mention. These units are 15-minute increments. And so it may look a little, and you'll notice here, annual projection, how many 15-minute billable increments are anticipated. And you may think to yourself, well, this is weird. How can you only do a 15-minute intake and assessment? This is actually, and so I'm going to talk a little bit about nuances. Normally, I see people who are spending 60 minutes to 90 minutes. So you may actually have 4 to 6 units. This particular intake and assessment I want to talk about this too. This is an inpatient setting example and an intensive outpatient, I apologize, with Recovery Bridge Housing Services. So they have already connected this person with a warm handoff. So this initial little intake and assessment is actually only 15 minutes. But normally you'll see things more like, and I'll just enter it to make it a little less confusing, 4 to 6. I've seen it as high as 8. So you can add how many of our 15-minute units you would actually be using. And again, if someone's transferring from one of your levels of care to another one, this might not take as long, but if it's someone coming into your organization, you haven't met them before, you may spend 6 units. All right, I apologize for jumping in, Andrea.
Oh, no need to jump in. Always happy to have help. And so under the group counseling, you see it would be the number of units. And so here we have 10. So at this agency, it's 10 units. If you scroll all the way to, what's that, 67, so if you go to H67, if we scroll down, that gives us our calculation. So there's a calculation there in H67, that cell, and what it's doing is it's adding up the total number of sessions and then multiplying by 4, which is the number of units in an hour. So here in this column, you would not put the number of hours, you would put the number of units. And I know that's been a bit confusing to quite a few people. And you'll notice if we go back up to cell H6, you'll see that's also a calculation. So instead of it being the 32, instead of it being the 3201, it's 18.67. And this is what this is a rate that you will receive, correct me if I'm wrong, Amy, per client or per patient for for 10 units, for 10 units weekly for 12 weeks for this particular, or for one individual patient.
Yes, the joy of this, and this is kind of weird, but again, once people start entering information in there, it becomes it makes more sense. And again, when we're doing it hypothetically with, somebody else's numbers, it may look a little strange. But so all of the calculations, because you'll notice that if you print it, and again, I'm going to quickly take a minute to pull up a resource. Here's your rate standards matrix that's on the SAPC website. And you'll notice all the way down at the bottom, there is the calculation for groups. And so it's basically mimicking this, all of this information here, this group counseling and patient education calculations, so you don't have to do this. So these formulas at the bottom half of this, the rates matrix, have been calculated for you, which I think is just a blessing, because that would be, I find that to be pretty daunting to calculate that. So that's what has already been done for you when you entered your information here. Hopefully that makes sense for people then. Because that's different. It used to be if you had a person sitting in the chair for group counseling, you got a full payment rate, but now you calculate based on the number of individuals that are in your group, and that's how that master calculation gets worked out.
This is, someone commented that this is all really great information. They just wanted to verify you'll be doing this also for residential.
Yeah. This is obviously, when you're doing residential, you're not getting any money for it, but you still need to calculate how many people are in a group and how many sessions you're doing, because that first tab we did about how many staff you need needs to be calculated, but there's just a whole different kind of payment practice to make it simple. All right.
Correct, because if I'm not mistaken, when it comes to residential, the reimbursable services are for the residential day rates and for room and board and case management.
Correct.
But as Amy said, you still need to track all of your sessions.
Yeah.
Okay.
All right.
And so you get your total over, so here in rows X and Y, you get your total units. And so you get the units in units, and then you get your total claims and dollar amounts. And then if we scroll down, and you'll see at the bottom of X and Y, you have your 274, which is your total number of units per patient. That should be per patient. And then your total claims, which is the 7,257. And this information will go forward on additional tabs.
Correct. And as Andrea mentioned, how you estimate this is it's for just one client. It's what your average client does. And quite frequently what I see people doing is just really looking at, part of it is if you're looking across your service continuum, IOP and residential, it's a little bit easier because you have more fixed programming that people go through. In an outpatient setting, what you want to think about is someone comes to you, they have a problem, you're going to help them get through their recovery process. How long, do you have someone staying in your particular setting? If you're doing straight up recovery in an outpatient facility, you look again at your rate standards and matrix. You want to at least meet your minimum and maximums. So you could just start calculating what those are and go from there. And then you might want to cross-reference, pull some of your case files and see if you're actually meeting those minimums. Intensive outpatient, again, that makes it a little bit easier to figure out because many times I find that they're sort of, and it's both good and bad. We have these therapeutic interventions, but they're sort of, I don't want to say one size fits all, but you have a series of group offerings and everybody is sort of mandated to go to them. First of all, when you start to, think about your treatment plans, it may not be as mandated quite so strictly. This is what everybody does on Monday. This is what everybody does on Tuesday. This is what everybody does on Wednesday. Again, that's sort of the residential intensive outpatient. You may start to mix that up a little bit. Outpatient, again, I think we have our special services group. Yours are probably going to look, really different, and, to really sit down and kind of figure out what is your average for one individual is something that you would benefit from having conversations with your team, business operations, clinical, looking at, do women have different sort of service continuum than your men? What does that look like? So you'll be actually having more discussion and have to make, I'm going to say this first year, because you weren't tracking this kind of data, you're going to have more assumptions that you're going to have to kind of, your best guess is what you're going to do. If you're running a residential facility or an IOP where it's much more mandated, this is how many services someone should be in. Otherwise, they should be going to a different level of care. For instance, if you're not meeting your specification of getting your provider units in residential because you just can't get enough of them, well, then you have to start looking at justifying why that person is in residential and maybe why they're not in intensive outpatient. So this is just done for one person. And again, if you don't know where to start, you can just start looking at your matrix and think about what is the minimum number of services I have to provide and what is the maximum that's considered sort of a best practice. And again, for residential, this is I think it's much easier to fill this out than it is even for outpatient services, but not overwhelming. And in outpatient, straight up outpatient, you'll notice that you might get people into, you may do recovery support services. So you might actually be calculating some of this recovery support services in your outpatient. In intensive outpatient, it may mean that you're moving someone to a different level of care, and so you might just have to have a separate spreadsheet for recovery support services. And again, those nuances, it kind of depends upon what level of care each of you provide. So if you have more specific questions about that, that's a great time to just don't hesitate to pick up the phone and call me, or if you're coming to the workshop on the 13th, we can review in more detail how that would look for you. But again, once you put it in, you'll notice that all of this calculation has been done for you. And Andrea has checked those formulas once or twice, and they work.
Yes, they do. Thank you,
Yeah.
Amy. And so here at the bottom, where are we? If we go to the bottom of this, there we are. Rows 67 through 70 gives you your total units per HCPCS. So, for example, for assessment and intake here, we have 4 total, and then for the initial plan, we have 5. And then the total cost for assessment is $128, and then the total cost for the initial treatment plan is $192. And then it also gives you your total number of sessions and your total number of staff hours, which is really important when you're working to project your capacity and your revenue. And then if we were to go over to the right, you'll see that those are all summed. And well, I'll fix it out. I'll make sure that they're all summed here in X and Y. So I already have that as a note, Amy, to do that.
Mm-hmm.
And then you'll see what the total dollar amounts are, and you'll see what the total sessions are and the total units are.
Right.
With that said, if we...
Yeah. Oh, I just wanted to say, too, that to me it's sort of confusing to talk about this as being total cost. And that was sort of a SAPSy term because that's, what they're allowing you to have. But you can also think about it, that's the amount of money you'll get reimbursed for providing those amount of services. Cost, I think, I'm not in love with that term. And I think what would be interesting when we have our meetings more face-to-face, or if you want to just type into the question box, what would be a better definition for that? Because I think that's confusing. I'm done.
Okay, thank you. And you'll see once we go to the service unit model how these amounts are transferred over. Oh, here we are. So here, as you can see in cell 14C, so for screening, remember we had 0 there. And so there's a 0. For assessment, we had 4. And then for the initial treatment plan, we had 6. So all of that information is transferred here. And even if you were to go up to the explanation, it shows you that it comes from the service model projections. For whatever reason right now, the name of that escapes me. But so you'll see that all of the information is transferred to this tab. Amy, did you want to continue? You can just hit escape. There you go. And so at the top where it says outpatient treatment, so if we go to episode duration, the number of weeks, here for this organization, the number of weeks is 12. And then for the direct service staff, FTEs, if we were to go back to the program budget and look in cell B24, you'll see that that average is a 2.9. If we scroll up, I see, it's different.
I'm actually going to send you back to the one that we filled out, not our service projecting, but the reason it didn't tally was the 9.2. And again, I've been playing with the numbers, so this is back to our original, not the baby one, that's the big one, but now we're not going to see the bottom. So I kind of made it confusing for everybody, and I apologize. That was no good.
So I have a question that came in. The person says they have 20 units of case management per person, and it calculates as only 3 total sessions. This is a question about the total session. What am I missing?
Again, out of context, that's a little tough. Would they feel comfortable giving me a ring and we could talk real specifically, like which cell they're in? Because I would need that level of detail. Which tab, which cell? But those are great questions to ask. If you're coming on Friday, we can cover it there. Or if you're not, then I would, highly recommend just give me a ring.
Great. Thank you, Amy.
All right. And Andrea, I'm going to go back to this one other than we'll just have to kind of help people understand. We have a little different direct service staff here, but it's filled out. We have 2 here. You'll notice that the big giant one that I had, that was specifically, we were just doing outpatient numbers. This is an organization's intensive outpatient, very small number of people. It's just 12 people in for 12 weeks. The that one that looks like I put it under a microscope, that was for straight up outpatient. So trying to give you an idea of, what differences there can be, but in a way, I feel like maybe I just made that a little bit confusing. And again, I apologize.
But Amy, even so, where we have direct services staff, so we could go back to the very first tab where it says program budget. And if we were to go to the top, we could see that the total FTE is 2.91. That's in cell B24. So we can still show how information on one tab transfers over to another tab.
Yeah, great.
Thank you, Amy.
Yeah. And then again, Andrea showed you that all of the utilization model gets transferred over from information you've put in different sheets. And we'll both kind of cover this top part, make sure we don't forget anything. Your caseload per FTE, again, that's kind of a guesstimate. And actually, when Andrea and I were looking at this spreadsheet, we noticed that there's only 2.9 staff people. There's always only 12 patients. So their real caseload isn't really 8, because with 3 people, 3 times 8 is, then you could have 24 people. So probably more realistically, their caseload is more likely it's going to be a 4, because 3 staff divided by 12 patients, or it might be, maybe a 4.1. And this is a number that you get to actually enter. It's not a formula, and it's not doing decimals. So you might even just say 5. Maybe that intern doesn't take a, full caseload, but that you'll see later is going to impact the number of staff you need to have in order to provide the number of units. All right. And this, again, is something you do individual sessions, how many hours. This is hours, not minutes. Again, on our first sheet, we calculated 60 minutes. So that's 1 hour. You could have this be a 1.5 if you do 90-minute sessions. The same thing with your group session hours. And then their average attendance per group is 12 people. Sometimes it's 11 if someone, doesn't feel well, because again, remember these are people who are coming over from Recovery Bridge housing into their intensive outpatient, so they know it's a fixed group of 12 people. They usually remain, with that number of people per group. Your static capacity and dynamic capacity, those are formulas, and you can look at it's pulling cell 52, C3, and it's multiplying it times C9, and it's actually calculating that for you. So again, you don't have to add those numbers. And then generally speaking, there's 52 weeks in the year, and that too is a fixed number. If you know that you're really closed, 4 weeks. You shut down your system. Maybe you're running an outpatient program and you close down for an entire week you could be in a culturally sensitive area, and maybe you close down for a holiday week because people won't be coming into your services. You could change that to 51, but generally speaking, we see most groups at 52 weeks that they're serving customers. Good. And now the joy of this is looking at total number of units, and you'll start to look at what the dollars and cents show. And what it's going to calculate for you then is the other thing that you have to kind of itemize is what your no-show rate looks like. And if you aren't really sure what your no-show rate is, you can easily track that, just by doing, ask the people at your front desk for maybe a week just to calculate how many people are not making it. This is primarily, the no-show rate is a little bit harder to calculate often when we're doing outpatient programs. So for a week, just have your front person that does reception and does, is the one who greets and meets and make sure that people get into the right service. Just have them sort of take a tally of how many people were supposed to show up for an appointment and they didn't. A no-show is someone who doesn't show up for an appointment. If somebody reschedules and you were able to book an appointment, that isn't considered a no-show. A no-show is when you had someone who, it would throw off your group size. You thought you were going to have 12 people and you ended up only having 9 consistently. Or you thought you were going to have an individual therapy session and somebody didn't show up, so you had a clinician who is expecting to see a patient and they weren't there, so the clinician now wasn't having a billable service. You really want to have a handle on that, because you'll notice that when you start playing around with that number, first of all, you can estimate, I have a 20% no-show. In an outpatient setting, 20% is actually pretty low. I would say it's probably going to be more like 30%. If it's more than 30% in an outpatient setting, that's a great place to start looking at making process improvements, because you'll notice that is a real drain on your finances. You can just see the amount of money that will be affected by that no-show rate. And your disallowance rate is how much money you lose because your claim is denied. And generally speaking, 10% is probably an average of denials that you'll have. If you have higher than 10%, there's usually some process improvement projects you can do again to improve that denial rate. Most of those would be something that you could probably correct. I know that right now, because of Sage implementation, this is like a wild card. And so you might want to look at what your denial rate is right now. And some of those issues are probably system level issues where there was some information, there was a problem with transferring your patient data, or maybe your therapists, not all of them had access to the system. So your denial rate might be a little bit greater than it will be on an ongoing basis. Again, 10% is sort of industry average for, I'm going to call it like the normal wear and tear of the industry. If you can get it better than 10%, you're doing really, really well. But you definitely want to factor in that, in a perfect world, you're going to get some denials. If it's higher than 10%, there's probably, again, some things that you can do to improve your denial rate by looking at, what sorts of problems are you having with claims? Is it, documentation isn't correct, that, the service isn't matching up with what we said we were providing? Does it have something to do with we're not writing in our correct ICD-10 numbers? Something that you actually can fix at the local level. It's no longer a system issue. And then at the very bottom, you'll see that this program, if they run everything as they say they're going to, you'll notice there's either blue, that means that you actually have a little bit of a profit. In this case, there's $170,714 that they're over right now. So if you were looking at that and you were starting to track it, and it's, now is a good time. Next year at this time in May, if you look and it looks like you have $170,000 over, chances are you're going to think about, maybe this is an appropriate time for us to give raises to our staff. Maybe we really do have enough money to hire another clinician. And those are the decisions that you'll be able to make based on whether or not your program, and that's another reason why we say this is a great thing to, start projecting your revenue and capacity. This year, it's going to look really iffy and you're not really going to know, but if you do the same thing next year using the numbers that you have from this year, your projection is going to get more and more accurate. And so you're not going to have to worry next year. When you see $170,000 in surplus, you're going to say, yep, that's a real number. We should be spending that money to improve our programming, increase our services, do more outreach, hire someone to help us do the billing because, maybe your denial rate is a little bit higher. So you'll be able to make those decisions because you're going to be able to see if you have a surplus or a shortfall. If this person, as we start to increase our no-show rate, notice if you have a 50% no-show rate, look what happened. We went from $170,000 in surplus to only $5,000 because we were losing $439,000, almost $440,000 a year because our no-show rate was so high. And that's a big mouthful, but this page is really, I think, you wrap it all up and you get to kind of look at it, sit back and go, I have some good information to make good decisions. And for me, I would feel much more comfortable knowing that I had an idea of what my service capacity was. And then we'll go to staffing model. And Andrea, did you have any, I should go back to service unit model. Did you have any other tips or any other ideas about what people should be aware of when they're filling this out?
No, you covered it very, very clearly and concisely. Thank you.
Okay, great. And then here's our staffing model. Again, one of the things that I'm hearing from a lot of people, and this is normal, part of it is because the life has been, in the last 6 months, has been pretty hectic. There's been a lot of clinicians and counseling staff and administrative staff have been out in training. So your normal business may not be what normal is to you. But we've also, I hear a lot that people, the clinicians feel like they have to see too many clients or they have too many groups or they don't know if they can get their medical documentation done or do I have the right case size load? And this staffing model is really where you're going to get some of that information because if you look at it over here, you'll notice that we said that overall for one individual and then it extrapolates and gives it to you for totals based on what your total capacity is. You need 63 hours staff time. You need 63 hours to provide the assessments that you said you were going to have in a year. You need 94 hours to do the initial treatment plan. You need 1,511 hours to do individual counseling, and you need 7,550 hours to do your group counseling. And then it looks at, how many sessions per week your staff is doing, and you'll look at the bottom of it then, and it'll show you your annualized staff productivity. So when you did that, you talked about, what their paid leave was. We talked about how many staff we had on board and how many hours they worked, and you'll get a really nice look at, what percentage of their time they're doing these different things. You have to, obviously, you want to look at paid leave. You want to calculate that in. And then it tells you what your total hours are for your budgeted FTE. And in this particular case, these folks did a really pretty good job of guesstimating or estimating. And I say guesstimation first year, estimating and, getting really close the second year. Were they over or under is how many billable staff they had and how many hours they had allocated. In this particular case, they had this particular person they have 114 hours that they're over. So that means that they're a little short for the program that they have, and they only had that 2.97 hours person, just a little less than 3. They actually need 114 more hours. So that would be, if the clinicians in this organization were saying, we just don't have time to get our medical documentation done, you'd look at that and you go, you're right. We're a little short. We have to think about, our program? Is there a way that we can allocate some more time from another person into this program? Because again, if they were doing more than their minimum standard, are they going to reduce the number of services that they provide, or are they going to hire staff, or are they going to, if they have 2 levels of care, are they going to maybe just take, can one of their other programs, in this particular case, they have residential also, could one of their residential counselors come over and just fill in the gap? But that's what this particular sheet will show you, which again would make me feel very comfortable at end of day, knowing that if my clinicians were saying their workload is really too great, you'd be able to look at it and go, you're right, it is too great. This is how many service units we need, and this is how many payroll hours we have. We're short. We can't do it all. And that's it. That was really long. We're about 21 minutes over our hour. So I kind of want to cut it short. If you have additional questions, you can quickly type them into the chat box and we can get back to you as a group. Or most of you should have my number by now. Kim is great at always making sure we have a good follow-up post-webinars. She'll send you the 2 spreadsheets again. She'll also include my contact information and her contact information. So if you have additional questions, we really encourage you to ask us. We have a session that we're doing on the 13th, so people can really get started. If anybody's having issues about that, or they have specifics they want to address regarding Friday, please contact me as soon as possible so I can get your questions answered prior to coming in. And Andrea and Kim, do you want to announce the other 2 sessions that we will have to review the material again? And this will be a larger group. It won't just be the people who participated in Collaborative 2. It'll be anyone in SAPC.
Yes.
Kim, do you have those dates?
Yeah, April 26th is confirmed, and then I'm working on confirming a date in May as well. So you should have received a link to register for April 26th. There's a morning for residential treatment providers and an afternoon for intensive outpatient and outpatient providers. And then we'll send you more information about the May session once we have that confirmed.
Great.
Thank you, Kim.
Thank you. Are there any other last-minute questions? And again, we really encourage you it's much easier when you come to one of the training sessions. It's a lot easier to come if you've actually put some numbers into these cells and practiced with it a little bit. Because you'll have a better idea of what it is that you understand and what you don't understand. So I highly encourage you to, if you have got more than one person coming in for the training, one person might want to look at the financials of, inputting all the information on tab 1 about salaries, wages, and expenses. And you will probably need someone from your clinical department to help you figure out, how many units of service are we doing. And having that discussion prior to coming is great. Otherwise, we will spend a little time having an opportunity to discuss it during the session. But those are the kinds of questions and decisions you'll be making as you go along the way and fill this out. So it's more than a one-person job in many cases. I think that's it, though. Unless anybody else has any questions. And again, I'm kind of sorry, I really sort of hate to cover it's hard to sit through a webinar discussion with a spreadsheet, but I really appreciate it. And hopefully it laid some groundwork for a better understanding of what goes in what cells. So you feel comfortable trying it out. And then if you need more assistance, we can do webinars where we'll actually have you pull up your spreadsheet. We'll set up a webinar, so you, much like I did, you'll see my sheet, only we'll have you share your sheet, and we'll be able to talk you through individual cells. Coming to the workshop and hearing from other people. I do like the idea of going to workshops many times because you'll get ideas from how other people are doing things, what's their caseload, maybe, how many hours of services are they able to, provide to their patients. So you also have an opportunity to share ideas with your peers, but there's lots of ways we want to be able to provide some technical assistance, so please don't hesitate to reach out.
And Amy, on the April 13th in-person session, are you also going to be doing a walkthrough of the residential spreadsheet?
Yes, and I'm glad somebody asked us though. Is this by any chance, is this Little House? And I know other people have it too, but let's quickly, if people have time, we're going to stay on the line. If you don't have time to sit through residential because you're primarily doing the outpatient, I will say too, some of you who registered, you're providing both, many levels of care. So we want to make sure that we do kind of touch base on that. And I can quickly, the one sheet that's really going to be different is going to be our, I got to pull up another sheet. It's going to be this program budget and the service model projections, and we can quickly review that, but I certainly would understand if some of you have to leave the call, and whoever had that question, are you able to stay on just really quickly, because I've got the tab pulled up right now.
They're currently on the line, so.
Okay, great.
Oh, they said yes.
All right, excellent, good. I also, every time I look at this, I find a mistake. Revenue didn't get spelled correctly, but we'll figure that out later. So here is your residential services. And the biggest difference, you'll notice that your program budget, that really looks exactly the same. Tab 1 is exactly the same as it was in the intensive outpatient, except for I made that one disclaimer about here's a line for you to itemize your room and board. That's not necessary. We do it as a, we would recommend that you break it out just because we know that if you get a state audit, they're going to want to make sure that those costs aren't, somehow figured into your indirect cost, your services, supplies, equipment, and facility rent and lease, because they're not paying that out of the state funds. This is coming out of county funds that, that SAPSI was able to allocate from a different pot of money other than the CMS money. So it's important to kind of just have a good handle on what those expenses are. Make sure that somehow you've got them broken out from your other expenses. And how you do that is up to you, but it's probably just as easy to do it right here on that one line budget item. Okay, so then what you have here is you have the same thing that we had with the intensive outpatient, but it's a little different because you'll notice you still have insert your level of care rate, because that depends upon if you're a 3.1, 3.3, or 3.5. Those rates shift just a little tiny bit, and it's not even necessarily, definitely part of your calculation, but I think it's nice to kind of, think about this. For instance, if you have 3 levels of care, if you're providing residential 3.1, 3.3, and 3.5 in your organization, when you do your cost report at end of year, and again, please check in with your financial analyst at the county, but my understanding is that you're going to have to itemize by every level of care. So if you have some patients that are 3.1 and some that are 3.5, you're actually going to have to be able to differentiate between expenses and staffing for 3.1 versus 3.5. But that has been something that I know has been sort of under consideration, and I do not know what the final answer is. So I would really suggest that you stay in touch with your analyst and find out what the latest news is. In residential, again, patients served usually 12, but if you've only got 8 beds in your residential, then that would only be 8. And you're doing your calculations here again. The one joy of this is you get factored in that you're providing these services, but again, you'll notice that the HCPCS codes are listed. They're all the same, but when you look at the unit rate, it's all 0 because your rates are actually being calculated here in the green area over here in your reimbursable services. But you still, such a big part of how many staff you have on board is how many of these services you're providing. So with this spreadsheet, even though you're calculating it at $0, you still want to look at what your calculations are for those service units. And so you would enter it just like you did, like we did in the outpatient spreadsheet, except that there's no actual dollars connected to any of these HCPCS codes. But again, for 3.1, you have a maximum and you have a minimum number of services that you need to provide. So you want to really kind of gauge that to see how many hours of service you're providing, and are you meeting those minimums, because that's going to affect your cost reimbursement. Maybe not so much this year as it will in the future, and making sure that you are providing the services that you say you're providing in your actual facility. So again, you would still do an intake and assessment. It's 8 units was calculated here. You did do a treatment plan, also 8 units. You're going to do 8 units of individual counseling the first day that someone's in. And in this particular case, we guesstimated that the person they came in early in the day, and they're even going to start to do some group counseling. This week 1 will vary quite a bit, and you'll know, and a lot of times I find it really varies based on your ASAM level. If you're doing someone with a 3.3 and they're doing some detoxing, what you can actually get through in a day may be very, very different. So again, if you don't know, just kind of look. Now you've got some records under the new DMC waiver. You could go back and look at June and July and kind of see what that looks like when someone comes into your organization. How many service units do you typically provide in week 1? How many do you provide in week 2? And then you kind of go back and you want to look to make sure that you're hitting your minimum and maximum. Then the other thing that you have to do, an additional calculation, is just look at what your residential day rate is. And since, remember, this is calculated per person, and if you're providing 7 days of services, then you get to say that you're going to get 7 days of your residential day rate at $125.23. And you'll also get 7 days of your residential room and board rate, and you add that here. If, for instance, and I know this right now is a factor for some people, they're not really providing any therapeutic services on one day of the weekend. They may provide them on Saturday, but they're not providing them on Sunday. Well, then you would need to put that down to a 6, and you would still get your 7 days of residential room and board rate. But again, in week 1, lots of times I find that people can't go out on a day pass. So oftentimes people are getting their full residential day rate for providing services and their full residential room and board. And then what you want to look at, because I kind of call this the butter on your bread or the gravy on your potatoes, it's the case management. That's new, and it's one of those services that our staff aren't necessarily attuned to documenting and really having a formal plan of, are we doing case management? Again, it's dependent upon your program. I know some programs have dedicated people who are doing case management. Other programs, counselors also have to do case management. I think it's even harder to differentiate than, did I do a case management service or if I didn't? So having a conversation with your team to find out what those case management units look like is really important. And that's where those actual services that are getting reimbursed, they'll go right here. And you'll notice you'll get the same kind of a tally with the number of services that you're providing and the dollars that are, getting reimbursed. And I feel like you might be the one who had the question about the 20 units of service or something. So was it on this particular program budget worksheet that you had that question, or maybe it isn't someone who's still on the phone who asked that question?
Hi, Amy. We do have someone who raised their hand who'd like to ask a question.
Oh, perfect.
Okay, great. So Claudia, are you there?
I am. Thank you. Hi, Amy.
Sure. Hi, Claudia.
So I'm just trying to understand, and I may be comparing it to the old spreadsheet, but if you look across on week 1, and you the total units of, the total units. In this particular spreadsheet, it's adding the 7 that falls under the residential rate and the 7 from the room and board. So it's not really giving the accurate billable service units, right, to meet those 80?
You're right. Let me just check. I have to grab a calculator. I'm not sure if Andrea has her calculator out, but
our numbers were a lot kind of easier. So it was, I don't know, like a 40 and a 2, and I'm like, oh, that doesn't add to 48. So I was able to notice it that way.
So you're looking at the group counts. Oh, I'm sorry. Go ahead, Amy.
No, I'm looking for my calculator, so go ahead.
All right. I just wanted to be clear. We're looking here. We're looking in cell H14 at the 48.
Let me follow you. Sorry, H14. Yes. So if you look at the whole week, if you look at line 14, actually, row 14, you add all of them, right? Before we get to green, those are the units that we're supposed to be able to add to see if we're meeting our 80 units. These 2 7s, the 14 on T14 and U14, should not be added towards that total unit, right? I mean,
correct. Your case management would, but I'm only getting 82.
Yes, not the T14 or the U14. Those 7s should not be part of our service units to get to the 80.
You're right. That is.
So then I need to change the formula there.
Yes.
To not include
the T's or the U's, or even the R's or the S's, right? See, R's, S, yeah.
Correct.
Okay.
R through U should not be calculated.
Got it. Thank you.
Yeah, thanks.
You're welcome. I have other questions, but I'll call you.
He's a little wizard. Yeah, he's a wizard. That's exactly right. Thank you. Because, I didn't even catch that before this. So thank you very much.
You're welcome.
Not other things, but not this one. All righty. And that really, in a nutshell, and if we fix that calculation, this sheet will be, I think, much easier for people to kind of look at, because again, one of the things we mentioned is that it's so important to understand how many hours you need to provide the number of services, your minimum and your maximum. So that you can't do it without that. And this one is going to be, but all else with the other forms, this will be the same. And once we fix that error that Claudia from House of Hope found, you'll be able to get a better calculation. Good. Probably the total claimed dollars is right, but not the reimbursable. What's going to throw it off is the service units, but the dollar amount is going to be correct for that column. So our tan column over here, 14AB, that calculation is correct. It's the units that we're going to adjust. All right. That should do it. Any other questions, Kim? And again, feel free to toss questions into my inbox and we will get back to you.
Great. I don't see any other questions, but thank you, Amy and Andrea, for your presentations, and thank you to everyone in the audience for attending. As Amy mentioned, I will be sending a follow-up email with the spreadsheets and also a link to register for the April 13th in-person session. We do encourage you as you exit the webinar to take a few moments to share your feedback. And with that, we will conclude our broadcast. Have a great day.
Thank you.
Thank you.